speaker is Michaela Straznicka. Did I say that right? Straznicka? And she is the co-director of the thoracic oncology program at John Muir. And she graduated from the University of Miami Medical School and completed her residency at the Robert Wood Johnson University Hospital in New Jersey. And she's been practicing for over 14 years as the principal investigator of the John Muir ILCAT program right down the road. So, Dr. Straznicka.
Great, thank you.
Oh, and if anybody has questions, just pass them down.
Well, good afternoon. Thank you for taking the time out of your day. And it's great to see some very familiar faces out here in the crowd. Thank you, Dr. Kramer, for a great talk. It's just the forward button.
Oh, it's the right arrow.
Okay. So what I'll be talking about a little bit, covering over some of the topics that Dr. Kramer discussed, as well as some of the lung cancer diagnostic and treatment options. And you can see that's a cartoon of what a lung cancer looks like. Lung cancer obviously is, we're going to be talking about cancers that originate from the lung tissue itself as opposed to metastatic cancers. Sometimes patients do come in with cancers in their lung that came from someplace else. That's not going to be the focus of our talk today. And that's a nice cartoon of what our lungs look like. So again, some of these statistics you heard. The worst part about this the disease process is that it's actually not really getting better. Over the last 30 years, we have not really seen a decrease in the number of cancer patients. We have not seen an improvement in their survival, even with some of the excellent treatments that we have. And although in America there's a lot of education about smoking cessation and early detection, worldwide the number of cancers identified continues to be significant. And as you can see across the United States, the survival is right around 14% for all comers, but that number is significantly worse in some developing countries where smoking is more prevalent, smoking cessation is not encouraged, and in many cases early detection is not on the forefront of their technologies. So we'll talk a little bit briefly about some of the symptoms that Dr. Kramer talked about. Again, just because someone has a cough doesn't mean you have cancer. I always want to stress that patients do say, well, I had a cough, I had a fever, does that mean I have cancer? The answer is no, but it does warrant some of those symptoms, if they do warrant investigation and discussion with their physicians. And again, some of the problems with early detection is they don't have cancer. That's why that screening was so important that Dr. Kramer was talking about, is that many patients, in fact, most patients with early stage lung cancer don't know that they have it. They may find it by incidental findings for some other reasons. Obviously, the symptoms of cancers growing, letting us tell us our body that there's something going on, includes local, tumor invasion into some of the chest structures. Again, that includes things like a cough, shortness of breath, especially with exertion. Coughing up blood is always a big sign that I always tell anyone. Anytime anyone coughs up blood, that's a marker that they should be seeing a physician right away. Again, doesn't mean that you have cancer. It just means that that's one of the concerns that we should be alerted to as soon as possible. Horner syndrome is a specific diagnosis that includes changes in the eye, changes in vision that represents a cancer way up at the very top of the lungs. Again, when we start thinking about systemic effects, like that means that your whole body responding to a tumor, that can include things like weight loss, different what we call paraneoplastic syndromes, which can affect your blood tests, it can affect your bones. And then, of course, we worry about metastatic disease, which means tumor that's gone from the lung to someplace else. Some patients, their first knowledge that they have a lung cancer could be a seizure, a neurologic deficit, enlargement of lymph nodes, pain in their bones. These are, again, signs of disease that is spread outside of the lung. And again, each of these symptoms ends up being so vague that it's often very hard for patients to go to their doctor and say, oh, I just don't feel right. Does that mean I have cancer? Not necessarily, but these are some of the symptoms that can alert us to a cancer diagnosis. Again, when we talk about the surgical results, so surgery means removing all of the cancers. Obviously, the earliest stages are the ones we have the most success with. Earliest stage, being stage 1, is in 1A and 1B, includes tumors that are only in the lung tissue itself and have not spread to any place else. They haven't gone to the lymph nodes, it hasn't gone to any distant sites. Those have our best 5-year survival rates, and in most cases, surgical treatment is recommended up front for stage 1s. Stage 2 is a more advanced cancer in that it's still within the chest cavity, but it can spread into the lymph nodes within the lung tissue itself. Basically, that implies that the tumor is smart enough to it's figured out how to get from one place to the other. It has learned how to work its way through the lymphatic channels. In many cases, stage 2 is still something we would recommend surgical treatment for up front, but in some cases, or in many cases, we would recommend chemotherapy afterwards. And when we start getting to stage 3 and stage 4, those are tumors that have kind of gotten really smart, and they know how to get from the lung to every place else. Stage 4 is metastatic disease. That means that it's spread to other parts of the body, again, including the liver, the adrenal glands, the bones, the other lung, the brain. When we talk about surgical results, there's really no survivals that would be treated with just surgery to the lung alone. Wouldn't make sense to take out a lung lesion if there's other spots elsewhere. Doesn't mean that there aren't treatment options. It just means that surgery up front is rarely recommended. And again, we look at more what's called multimodality therapy, including things like chemotherapy, radiation, hormonal therapies, and some of the new biologic agents we'll be hearing about. The key with that is obviously the opportunity is the smaller the stage 1 lung cancer, the better. Again, we always think about stage 1 being the ones that are the most successful with surgical treatment. You can see if a stage 1 cancer is very small, 1 centimeter or smaller, the chance of 10-year survival is up to 93%. Even within that stage 1, as the tumor gets bigger, the the survival does decrease in size, in amount at the 10-year mark. Which is still, 50% at 10 years is actually still not a bad number for larger cancers. We're actually looking at some of the adjuvant treatments that we can offer patients with large stage 1 cancers. But again, the idea is that most patients, they will still benefit from surgical treatments up front, followed by additional treatments if necessary. Again, lung cancer screening, I can't stress enough how important screening is. The idea is that you don't wait for someone to have symptoms. If someone is high risk, you want to intervene as soon as possible, and you want to offer them curative treatment. Again, if you look at the slide for lung cancer, the incidence is high and the cure rate. And the word cure means that at 5 years from the time of diagnosis, that the patient has no signs of cancer anywhere within their body. So when you look at lung cancer, the cure rate is so abysmally small because, as we talked about, so many patients are not found in the early stages. So if you look at lung cancer versus colon cancer, breast cancer, or even prostate cancer, those 3 have screening modalities, which means you take patients, you just think they may have the tumor, you say, well, let's subject you to a test. Again, colon cancer being a colonoscopy, breast cancer being mammography, prostate is just a blood test at this point. You can find those cancers much earlier, and therefore we've impacted the survival of those patients dramatically compared to lung cancer. Again, we are hoping that within the next year or two, we're going to have Medicare approval for lung cancer screening, as Dr. Kramer talked about with low-dose CAT scans, and I'm hoping that our graph for lung cancer is going to start looking more like the colon, breast, and prostate slides up there within the next couple of years. What are the x-ray tests? Obviously, we can't see our lungs. They're not like breast cancer where you can, do self-exams where you can look for masses, which is, recommended, of course. But in terms of lungs, there's no way to look at your lungs other than x-ray tests. And the multiple tests that are offered include x-rays, a regular chest x-ray, which is a very easy test, doesn't take very much time, low radiation dose, but unfortunately not very accurate to find lesions that are small. Really hard to see things that are 1 centimeter or smaller on just a regular routine chest x-ray. CAT scans, which have really taken over the role for what we're hoping is going to be screening, because you can see things as small as a couple of millimeters in size now. As we get further down, the tests that we're looking at there, PET scans, MRIs, and bone scans, those are more specialized tests that look for very specific things. I don't want to go into too much detail, but I can answer questions if you guys have about the role of PET scans and MRIs and bone scans. Most of those are patients, once we identify that their lung cancer is a diagnosis, we would use these to help us find that stage, how advanced the cancer is, and to plan our treatment. So right now, kind of chest x-rays and CAT scans are our first tests that would routinely be ordered by our physicians. And once a diagnosis is made or highly suspected, PET scans, MRIs, and bone scans can be helpful and are oftentimes used. So again, we talked about the early detection. Again, screening is not yet covered by insurance, but we're hoping to see that come through in the next couple of years. The NCI study, which is a study that was actually pivotal in some of the screening tests. They took a high-risk population of patients, 50,000 patients who were considered high risk. They were heavy smokers, many of which were active smokers, and they compared the use of a CAT scan versus just a regular chest x-ray. And this study showed so much improvement in early detection and survival with CAT scans versus chest x-rays that the study was actually aborted halfway through its planned enrollment because it was unethical to continue the study. It wouldn't make sense to subject patients to chest x-rays knowing that they're an inferior test and people were dying of their cancers when you can identify them by CAT scan and influence treatment. So that trial, actually, we were not involved in here at John Muir or in Northern California, but it was closed, and it led to a lot of the recommendations we're hearing about low-dose CT scans. The ILCAP study that Dr. Kramer mentioned briefly, as well as the family study, are both actually active studies that are still available. Here at John Muir, we are participants. We're one of 50 centers that are participating in it. The ILCAP, just briefly, is again, a low-dose CT scan study that looks at smokers and previous smokers that are considered high risk. The family is kind of the sister study to it. Very similar usage of a CAT scan, a low-dose CT scan for those patients, but the family are patients who are exposed to secondhand smoke and have been considered never smokers. So that's actually a really important study because it's actually identifying that non-smokers are still at risk, as we know, of developing cancer, even if they're exposed to a certain amount of secondhand smoke. Now, once we find these cancers or these lesions, unfortunately, when you look at a CAT scan, you're going to have patients that have lesions all over their lungs, nodules, what we call micronodules to real-size nodules. I didn't put up the algorithm, but basically, everyone in America is going to have some kind of a nodule you're going to see on a CAT scan. If we CAT scanned everyone in this room, everyone's going to have a little nodule in their lungs. That's because we live in America. There's auto exhaust, there's pollution. Our lungs are susceptible to everything in the air. So obviously the key is not only to identify the lesions that are considered worrisome for malignancy, but then also prove what they are. In general, if we look at most CAT scans, nodules that are 4 millimeters or less are clinically insignificant and extremely unlikely to be malignant. As they get larger, we start getting worried. And currently, anything that's 8 millimeters or higher on a CAT scan is considered suspicious, and we should do something about that. Anything 15 millimeters or larger is considered cancer until proven otherwise. And that's where those cancer studies we're using as their cutoffs. But every nodule isn't cancer. So obviously you get this scan, you get this worrisome report, oh, there's a nodule in your lungs. What do we do then? The key now is not only to identify that there's a nodule, but now prove what it is. And one of the key things we have to do is accurately and safely biopsy these lesions to look for a diagnosis. Again, knowing that still most lesions that we find in the lungs are going to be benign. So we have ways to do that with what's called bronchoscopy. That's where you look inside the airways with a lighted tube and we can biopsy from the inside out. Some patients are better suited with a biopsy using a CT scan going from the outside in. This is to identify clusterings of cells within that nodule to then plan our treatment. In addition to identifying whether there's a tumor within that nodule, we sometimes take one step further and we want to look at the lymph nodes in the chest. Again, there's multiple minimally invasive staging techniques, which includes the EBUS, which is an endobronchial ultrasound. Again, this is an outpatient procedure. It's designed to biopsy, I think I have a picture of that, biopsy of the lymph nodes to help us identify which patients have advancement of their tumor in cases of cancer. And then, of course, if in those patients that are surgical options, we actually have the ability to do most surgeries now in what's called a minimally invasive approach, which is called a thoracoscopy or VAT surgery. Some people call it laser surgery, although there's no laser involved. And that being a way to use small incisions, minimally invasive approach to take out the area of abnormality in the lung, as well as the lymph nodes that may or may not be associated with it. Again, just briefly covering the treatment options. In general, we consider early stage 1 or 2. Those are the cancers that are confined to the lung. And stage 2 being those patients that are confined to the lung with possible lymph nodes within the lung tissue itself. Again, surgery is the mainstay of treatment. You want to remove that portion of the lung that's involved. And in some patients, we may recommend postoperative chemotherapy. It's for at least, especially for the stage 2 patients. Now, that of course involves having the ability to tolerate surgery. You know, obviously surgery is a big deal, even though we talk about minimally invasive approaches. Patients still have to be strong enough to undergo a general anesthetic and remove a portion of their lung. So we have found that some patients, just even though you find this little lesion and you know it's cancer, they can't tolerate an operation. There are some really excellent new radiation therapy options that have actually been proven to be very effective for patients who are considered too high risk for surgery. And some of those are not experimental, but early in their development. And but we're finding really good success rates, and potentially one day we'll be using radiation as an adjunct to surgery. When we talk about stage 3 and 3A and 3B, those are patients that may or may not benefit from surgical treatment, but we know that when they're stage 3, that the lymph nodes in the middle of the chest have now been involved. So we're not going to be able to just do surgery alone. These are patients who are going to need a combination of therapies. And by that we mean there could be a combination of surgery first, followed by chemotherapy, maybe radiation therapy. Sometimes we say, well, let's give chemotherapy first, shrink it, and then maybe go do surgery. In some cases, they're not surgical candidates. And this is where a very individualized approach with a variety of specialists becomes important, because this is where each patient becomes, it's very, very important to plan out their treatment. We're still looking for curative intent in stage 3 and 3A and 3B patients, but it's never going to be one magic bullet. And when it comes to stage 4, which is metastatic disease, oftentimes chemotherapy is the mainstay. Again, it wouldn't make sense to take out part of the lung if there's treatment, if there's cancer someplace else, so we want to treat the whole body. But chemotherapy can be traditional chemotherapy, it can be biologic agents now. We can recommend palliative radiation for parts of symptoms from, let's say, bony pain. And oftentimes we do surgery to palliate symptoms if there's fluid associated with the cancer, if there's particular areas blocking the airways. So we do have surgical options, but they're rarely the only treatment. And again, curative options get pretty limited as we get into stage 4. When it comes to, again, the surgical options, we talk about the bronchoscopy for diagnosis. Again, in many cases, what used to be a big deal is now not much of a big deal. Patients come in for an outpatient staging with a bronchoscopy. There's no incisions. There's essentially no recovery. In one procedure, we can biopsy the lesion itself as well as the lymph nodes using these advanced technologies. Once we get a diagnosis and secure the stage, again, if someone is a surgical candidate, the thoracoscopic or VATS surgery now allows us to do complete resections using 3 small incisions, the biggest of which is about 1.5 inches in size. We can still do everything we used to do through big incisions, but now through small incisions, which allows us to have a really short hospital stay, significantly reduced pain, and faster return to full activities. For those patients who need additional therapy, faster progression to their postoperative additional treatments. Again, this is kind of a cartoon of what that EBUS looks like. If you see the gray shadow behind, that's the bronchus that this scope is going through. The little round dots are the lymph nodes. And using an ultrasound is extremely safe. We rarely hit any of the important structures. Again, a needle biopsy that allows us to biopsy the lymph nodes as we see them. Again, allows us to stage patients to plan their treatment. And this is kind of what a thoracoscopy looks like. I didn't put up a scary thoracotomy slide because I didn't want to get anyone scared, but this is, again, a cartoon of what we do in the operating room. One of those ports is our video camera. The other 2 instruments are like Chinese chopsticks, so they're slender with openings at the very end. We use a stapling device for almost everything now. That's what the inner cartoon is, which allows us to identify the blood vessels, the lymphatics, the bronchial tubes, and we do all this with these 3 incisions. Again, it's still a major operation. It still has risks associated with it, but significantly better tolerated than the thoracotomies of old. And this is just kind of an idea of what a lung looks like. This is a very happy lung. I didn't show you the cancer slide, but this is an idea of what we're working with when we're working in the operating room. The lung has been collapsed, so we can see around it. You can see that this is the right side. There's 3 major divisions or lobes, and you can see how clear everything is, which really allows us to do really, really fine dissections very safely. And again, we can do pretty much most things that need to be done. Now, there are some patients who are not candidates for thoracoscopy, specifically really large tumors. Anything over 5 centimeters or larger isn't going to fit through a 1.5 centimeter hole. So we do have patients who actually require the the old-fashioned thoracotomy approach, which is still, with some of the new technologies and the better anesthetics, is still a very well tolerated procedure. The goal is to go for cure. And again, here at John Muir, we're very proud that we do have basically all the treatment options we talked about, all the different biopsy options that are here that we just talked about. In the country, only 17% of patients are getting thoracoscopic lobectomies because of limitations in training, limitations in equipment. I would say at John Muir, 95% of our surgeries are done with the thoracoscopic approach, which again is leading to faster recovery, less pain, more surgical treatment options for patients. And then, of course, the options that after that, let's say we get our pathology back and someone does require things like chemotherapy or radiation. Dr. Chen is going to be talking about some of the chemotherapy options, but we do have, whatever the stages of the patient, we do have treatments for everybody. So one of the good things about lung cancer is there's no one, irrespective of stage, that's not a candidate for treatment. We just have to individualize it for each patient.